Welcome back, everyone, to the PA the FI Way podcast. I'm your host, Kat, and I am so excited to have a returning guest on the show today. Before I introduce him, for the regular listeners out there, I'm a little bit sick, so if my voice sounds maybe an octave lower, then that is why, and please forgive me for that. But we have Dr. Jordan Grumet joining us again for the third time on PA the FI Way. Welcome to the show, Jordan.
Thank you so much for having me back on. I appreciate it.
Of course. And many people know you from your work on financial independence and purpose. You were back on episode 81, where you talked about your first book, Taking Stock of Your Life, and then episode 148, when you shared about the purpose code. For those listeners who aren't familiar with your work or aren't familiar with you, do you mind sharing a little bit about yourself?
Sure. When I was young, 7 years old, my father died suddenly. He was a physician. My brain as a 7-year-old thought I could make up for all this trauma that happened to me by becoming a physician like him. It was a long, tortuous path, as all of us in healthcare know, but I made it there and quickly burnt out and realized that it didn't solve my problems, like it didn't bring my father back. And being a physician as well as being a PA, an NP, pretty much anyone in healthcare nowadays is exceedingly hard. There's a lot of stress. And because I burnt out, I tried to find a way to step away from this profession that was exhausting me, discovered financial independence. That eventually allowed me to step away from medicine mostly. I decided I'd keep one thing which I really loved, which was hospice work. But it gave me a lot of time to explore other things that were important to me. Since personal finance and financial independence got me there, I started a blog and a podcast, and these deeper questions about money and what it means in our lives helped me realize that my hospice patients could actually tell us a lot about what they regretted and maybe how we as young people could think in a more appropriate way about money in such a way that it supports our goals and our lifestyle as opposed to becoming the end all and be all. And that led to a lot of conversations also about purpose. So basically, I ended up being the hospice doctor who was the personal finance expert who thought lots about meaning and purpose. And as you'll see, also about our healthcare system.
Absolutely. And in this episode, we're going to talk about your new book called The Healthcare Heist. Could you share a little bit about what led you to write about this book, which is a little bit different than your past books?
Well, it's interesting because I've always done deep thinking about medicine and the healthcare system. And one of the reasons I burnt out of medicine is I just didn't see it sustainable for most physicians. The economic model didn't work. The connection between patients and caregivers I was finding to be very strained. I always felt like there were all these third parties who were stepping into the relationship, whether it be insurers, electronic medical records companies, or pharmaceutical companies, or hospital administrators, or even the government. So I saw all of these problems to our healthcare system, and one of the answers for me was personal finance. And so it's very much connected to my own trajectory. But I realized that personal answer for me, becoming financially independent, being able to leave this healthcare system that wasn't serving me as an employee of it, didn't really answer the bigger and deeper question of, yeah, but what about me as the patient? Or what about all of those of us who need care? Or what about all those healthcare practitioners like you and I who don't have the luxury of financial independence and love their jobs and want to stay in them? And so I saw these crackings of the healthcare system. My financial independence journey made me think very deeply about these things, but I started to feel like there were some real answers to how we fix our healthcare system, not just how we fix ourselves by having good finances.
Sure, absolutely. And in the book, you talk about the concept of the culpability myth. Could you share a little bit about that and how clinicians have become the public face of problems that we just really didn't create ourselves?
Well, it's interesting. There were a number of things that happened really in the 1980s, 90s that have brought us to today. And first and foremost, I sometimes make the mistake of saying physicians because I'm a physician. But when I'm saying physicians, what I'm really talking about is all of us caregivers. So I'm talking about PAs, like a lot of your audience. I'm talking about NPs. I'm talking about physicians. I'm talking about nurses. But I'm also talking about social workers and chaplains and physical therapists and occupational therapists and respiratory therapists. I've really drawn the line that there are those who give care and those who receive care. Those are the main stakeholders. And you and I are part of that big, vast group of those who give care. Sometimes I make the mistake of just saying physicians because I'm a physician, but what I'm really talking about is all of us. And so what happened? Well, a few main things happened that changed the way the public thinks about caregivers. One was a study called To Err is Human. It was put out in the late 90s, and it said that up to 98,000 people a year die in hospitals because of physician and healthcare mistakes. And this was a highly extrapolated study. They took a few very narrow cases and extrapolated it out to the whole system. And it makes no sense. It would mean like 1 in 2 people who die in the hospital, they die because of an error. It clearly was not the case. But it became the fodder for medical malpractice. And so you have all these medical malpractice groups and lawyers and companies who really use that data to start convincing the populace that physicians and healthcare givers were really responsible for everything going wrong in medicine today. So all you have to do is look up the word malpractice, malpractice attorney, or even a lot of disease processes, and you'll get some lawyer website that talks about the study To Err is Human. And so this was a study that eventually there were many other studies and opinion papers that detracted it, said, look, this doesn't make sense. The extrapolation didn't make sense. This is non-scientific. But the harm was already done. So on one side, medical malpractice has convinced people that our healthcare givers aren't doing a good job. Now, most people don't realize that 68% of malpractice cases are dropped before they even make it to trial without their being found fault. 68% right off the bat are just thrown out. And then once you hit trial, 8 in 10 trials find for the physician or the healthcare giver and not for the plaintiff. And so the truth of the matter is we're not finding a huge amount of malpractice out there, but caregivers have been made out to be culpable. That's on one side. Now, the other side is our healthcare system has changed. Back in the 1980s, we had the rise of HMOs. And how did HMOs work? Well, you had a gatekeeper physician who decided what studies, what tests, and what referrals you would get. And so all of a sudden, the physicians who were never trained in public health and were never trained in the economic of medicine, they were trained and took a Hippocratic oath to be responsible for the good of each specific patient. We all of a sudden were doing population health. So not only was your doctor making mistakes that was ending in your death in the hospital, but your doctor was also the one who was responsible for denying your referral to a cardiologist or an orthopedist, etc. And it wasn't just HMOs. Eventually, as healthcare reform has occurred, we've had things like ACOs, accountable care organizations. And basically, there's been a lot of carrots and sticks by the government to make physicians manage the economics of care. And so your doctor's not only culpable because they're not doing a good job, but they're also denying you because they're greedy, right? Because that's what everyone thinks. The populace thinks because they're greedy, they're denying you the care you need. And so what this has caused is a divide and conquer situation where you have these third parties like malpractice attorneys, like insurance companies, like pharmaceutical companies, occasionally even like the government, that is divided and separated caregivers from those who need care. And all the while, these third parties are just taking money out of the system, and they're not really even involved in the day-to-day care. And so it serves many of these third parties for physicians / caregivers not to feel allied with those who need care, because then they can go ahead and rob us blind. And that's exactly what's happening.
Yeah, absolutely. It's pretty wild that there are so many external third parties that don't have any day-to-day actual use in medicine or roles in medicine, and yet they influence so much of what we do.
Yeah, look at electronic medical records. Electronic medical records were supposed to save medicine. They were supposed to cut down on medical errors. They were supposed to help physicians, nurses, everybody interact better between systems. And we have spent over the last few decades billions and billions of dollars. Medical records companies like Epic have made it rich. Their founders have become billionaires. And when you look at the studies in total, healthcare hasn't actually improved at all. Like, we thought this was going to cut down on medical errors, and it did in some ways. But then the electronic medical records themselves caused other types of new errors that we had never seen before. Communication is poor. Because hospital systems are owned often by venture capital and private equity, they don't want to share their data with other hospital systems. So we have these electronic medical records. The electronic medical records could talk to each other, but the different systems don't want to share the data because they don't want to lose the patients. They want you to come to their system, not go to another system and be able to access their information. And so we have these third parties. And again, electronic medical records is just a really obvious one that has cost our system billions. It's taken billions out of our healthcare system, and it hasn't helped anyone. We're no better off.
Absolutely. And you talk about how these different third parties pretty much use providers and patients as leverage, and they have their own incentives or their own views on how healthcare should be run. And I feel as though you wrote the book that a lot of clinicians have been thinking, right? You're writing about this topic that most of us are kind of venting about behind closed doors. So I appreciate that you shared about that. Are there any other ways that we're being used as leverage from your viewpoint?
There are so many ways. So I begin the book by talking about my epiphany. The day that pretty much my medical career ended, I was sitting watching TV with my wife and two young children. It was about 8 o'clock at night. We got a knock on the door. I went to answer it. And of course, it was a process server handing me my first and only malpractice case. A malpractice case that lasted 6 years. Cost a lot of money. I was depositioned. I had to go to trial. And eventually I was dropped from the case, right? So found completely not culpable. And the lawyer admitted in front of all of us that he never thought I was culpable, but he needed me as leverage to get the nursing home to pay a higher amount. In the meantime, that 6 years not only caused me a huge amount of depression and anxiety, caused me to practice way more defensive medicine, right? I was ordering tests and getting referrals I probably didn't need because I was petrified, but also eventually worsened my burnout, and I left my medical practice. And so because this one lawyer wanted to use me as leverage, it not only cost the system a lot of money, I eventually left my medical practice. I left all of the patients that I was taking care of, and some of them had dire consequences. Some of my patients died shortly after I left, partially because they just didn't have as much access to care. All the people who worked for me no longer had a job. Like, there were downstream consequences to all of this, and I was just mere leverage for this lawyer. That's just one case. And electronic medical records is another. But then you start looking at pharmaceutical companies, insurance companies, venture capital, private equity. They are all using you and I. And when I say you and I, I'm not just talking about us caregivers, but also us patients. They're using the patient's need for good medical care, and they're using the doctors, nurses, PAs, social workers, et cetera. They're using our sense of responsibility and our oaths to our patients to extract money from the system, and they're doing exceedingly well. Like, look at how pharmaceutical companies do compared to the rest of the S&P 500. Their profit margins are in like the top 10%. Look at what they pay insurance companies' CEOs. Look how often insurance denies care or makes you fill out pre-authorizations. Look at how often venture capital and private equity buys thriving medical systems, sells all of their real estate, gets rid of all of their equipment, bankrupts these hospital systems, and leaves after it takes the profits and leaves them in Chapter 11. All of this is happening, and it is bankrupting our system. You wonder why insurance premiums rise every year and have risen every year for the last 20 years. It's because we are paying out more and more money to these third parties, and they are getting really wealthy from the system, and they do not want it to change. And so they put a huge amount of money into Washington. They lobby. There are these huge entrenched interests. And so if you think we're all of a sudden going to have a politician who's going to come around and say, no, this isn't right, and change it, you know, they have a huge amount of headwinds stopping them from doing that. There's a big amount of money being put forth to make sure the system doesn't change.
Unfortunately, many of these decisions come down to money. Isn't that the case?
They do. And remember, you know, if you look at the history of our healthcare system, go back to colonial times, like it was your village members who were delivering your babies, and they didn't have medical degrees. They just had to learn because there was no one there. But when you start looking at why medical care started in the United States, it was for the public good. It was because we had wars, and so you needed doctors and nurses to manage people on battlefields. And then you needed medications, and all of that. The beginning of all of that was for public good. But after about World War II, everything moved to more of a for-profit model. And that's when we started concentrating on profits and not the good of the people that these systems were supposed to serve.
Absolutely. And you mentioned big insurance. I'm curious how insurers have become such powerful gatekeepers in healthcare. I know that the two of us, but almost every healthcare provider listening to this has wasted countless hours on prior authorizations unnecessarily, sometimes because they don't read the information that you send them and they missed a generic for the brand name and missed just silly things like that that just are soul sucking and suck our time away from us. So I'm curious, how did this happen anyway with these large insurance companies taking over?
It's funny. There are really two major mechanisms insurance companies are fleecing them. One is by denying care, and then the other, believe it or not, is by paying out a huge amount of care. And that makes no sense. So let me explain it. Denying care. You're 100% correct. There have been studies that show that for the average medical practitioner, there are 39 pre-authorizations per week, and most medical practices spend 13 hours per medical practitioner on just pre-authorizations. Insurance companies in 2020, they did a study and found that insurance companies denied 1 in 5 in-network claims. That's 42.3 million claims, and only a small percentage of them were appealed. So pretty much they almost all went through because people give up. So one is they deny care. But what most people don't understand is actually one of the ways insurance companies get us is they pay out a lot for care, which sounds counterintuitive. What people don't realize is Obamacare had this idea, right? When they passed Obamacare, the idea was insurance companies are keeping too much as profits. So what we're going to do is we're going to mandate that they have to pay out 90% of what they bring in on care. And they can only keep 10% for employee wages and for profits and all that kind of stuff. And so it makes sense. 90% of premiums have to go to care. That's supposed to improve the system. Well, what insurance companies realized? Well, let's say you are a patient and you need your hip replaced. And so you go to the hospital and the hospital goes to your insurance company and says, that's going to be $50,000. Well, in the old world, the insurance company would say, we're not paying $50,000 for that. We'll give you $25,000 and you're going to take it because we're going to send you 1,000 patients. And the hospital generally was like, okay, that's not perfect, but we're happy with that. And everyone was good. And so a hip was done for $25,000. Well, what has changed? Now that the insurance companies have to pay out 90% but get to keep 10%, they had no impetus to fight the cost of care anymore. In fact, they would rather pay out $50,000 instead of $25,000 because they got to keep 10% of whatever they bring in. And so the more they paid out, the percentage of what they got to keep was the same, but the more they paid out, the more they got to keep. So if an insurance company paid out $1 billion, it might be able to take home who knows how many million. But if it paid out $2 billion, it could double how much it kept. And then you're saying, well, yeah, but they had to pay it out. So where did the money come from? The money came from increasing premiums. So actuarially, the insurance companies would just keep on increasing premiums to cover their expected payouts. And as the expected payouts went up, they just increased premiums, but they kept a much larger amount of money because 10% of $2 billion is a lot more than 10% of $1 billion. And so they really get you on both sides. And that's just the obvious stuff. There's so many ways in which insurance companies have actually found that it doesn't make sense for them to investigate fraud. It's too expensive for them. So they don't even bother investigating fraud. They just keep paying out. Why would you keep paying out? Because they get to keep 10%. They're not even trying to police all the fraud that's going on. And so the more the system is broken, the better it works for them, the more money they make.
Very interesting. Thank you for sharing all that information and those perspectives too. I wanted to shift from big insurance over to big pharma. Again, you touched a little bit on big pharma, and you've described it as something of a bit of a hoax. What do you mean by that?
So it's the R&D myth, the research and development myth. Basically, pharmaceutical companies argue that the reason they charge so much and the reason they get all this patent protection is because the cost of research and development, R&D, is so high. But it just isn't true. First and foremost, they find that for a major blockbuster drug, the R&D is about $1.8 billion. but they make over $18 billion. So they make over 10 times. But here's the thing. They're actually not doing that much R&D and creating that many blockbuster drugs anymore. So they've done studies, and over the last few years, the number of blockbuster drugs has dropped, but what has increased is the number of Me Too drugs, drugs with minor modifications that treat the same thing that they can extend the patent with. So if you remember, for instance, omeprazole, a medicine that basically blocked pumps in the stomach that decreased acid production, omeprazole was one drug. But then all these companies started making other drugs that were very similar to omeprazole, but had minor modifications, right? So then you had Nexium. All of these other medicines that they did were actually just minor modifications of omeprazole that pretty much did the same thing. But because they were new drugs, they could extend the patents. And so they got patent protection for much longer. And so they're not doing as much R&D. They're doing minor modifications. They're delivering meds in new ways, right? Remember all these new pens we have for injections? You used to have to inject yourself with insulin, but now you have a pen. Well, that pen allows them to extend the patent, even though you're basically getting the same medication. But it goes further than that. The thing about it is actually most of these big companies don't even do the R&D anymore. What they do is smaller companies who spend a lot less on R&D actually create most of the new blockbuster drugs now, and the bigger companies buy them after they're already developed. So a lot of these bigger companies don't even do the R&D anymore. Other issues that we pay no attention to. Companies say, well, it takes a lot of research to do all this work, and that's why that's why you're paying us a lot for it. But what they don't tell you is that since 1930, the NIH has funded over $900 billion publicly for research. And when they did a study of every single drug that came out between 2010 and 2016, they found that there was not a single new drug that didn't rely on research that was NIH funded. And so the public is already paying for the research and development. We're already paying for all that great work that happens at our universities and that happens at the NIH and other places. And they're doubling down. And there are countless other ways. They get all sorts of tax benefits because of their R&D. Again, R&D that they don't necessarily do. But they do other dirty things too that we never talk about. For instance, a lot of these big pharmaceutical companies will pay generic producers not to make a generic. And so let's say you have a drug, it's coming off patent, and that drug makes you $1 billion a month. What they do is they go to the generic company and say, we'll give you $10 million every month that you don't make a generic, even though it's off patent. And if they can even stop them from making the drug for 2 or 3 months, they make billions of dollars on that. It is a dirty system where no one is really thinking about the well-being of the patients. Mostly we're thinking about the well-being of the bottom line of these companies. And remember, you and I, when we got our degrees and started seeing patients, we really were governed by 2 different things. One was some version of the Hippocratic Oath or the Oath of Geneva. It was an oath that we took saying that we would basically use our skills for good and protect our patients. But then there's also the standard of care. So medical malpractice, they can always come after us if we don't practice based on a certain standard of care. That's what governs us. But what governs these insurance companies, pharmaceutical companies, private equity, venture capital, you know what it does? What governs them? Fiduciary responsibility. What is fiduciary responsibility? It is an economic responsibility to their shareholders. And so these companies don't have to operate to the same ethical standards of patient care that we do. They have to operate based on a fiduciary standard, which means they make decisions that make them more money, not necessarily help them give better care. And so this is all of them. This is the medical records companies. This is the insurance companies. This is the pharmaceutical companies. This is private equity and venture capital. None of them have to live up to the standards that you and I face every single day.
Yeah, it's very invasive and prevalent, all these issues and the layers to it. And again, it goes back to lining the pockets of people that aren't the patient or aren't the provider. So again, I appreciate that you broke down those different third-party areas and some of the issues with them. I know that you go way deeper into those within the book, but let's transition and talk a little bit about the intimacy gap. You talk about this concept. I'm curious, what is it? Could you describe it a little bit for the listeners? And then how in the world did we actually get here where this intimacy gap exists?
So, first and foremost, we're now moving from the problem to solutions. And I wish I could tell you there was a simple solution or a simple bit of legislation that's going to fix all of this. But there isn't. So, to understand what I believe the true solution is, we've got to talk about how systems change when there are all these entrenched third parties. So how do systems change when they're entrenched third parties that control the government, control the economics? The only way they change within the US and outside is revolution. Now, I'm not talking about revolution where people are picking up bayonets and fighting. I'm talking about an emotional revolution where the people who are most affected come together and fight for grassroots change. We're going to get to the intimacy gap in a moment, but I think you have to understand kind of this background of why we're talking about this. So how do the main stakeholders come together to basically change a system? The way they come together is through shared storytelling. When we tell stories that bind stakeholders, that build intimacy, that bring us together, we get revolutionary change. And if you don't believe me, just look at Rosa Parks and the bus. The story of Rosa Parks and her sitting down in the bus became a story that bound stakeholders, the people who really wanted change in America, and basically eventually led to grassroots change where the stakeholders stood up together and said, we won't take this anymore, and brought about a civil rights revolution. We've had this in our history. It's not just civil rights. You can go back to Upton Sinclair. He wrote a book called The Jungle. He was a socialist, and he wanted to talk about what was happening to the workers in the meatpacking industry in the early 1900s. He wrote a book, and actually that caused all the stakeholders first to decide the way we were handling food was wrong, and you had all sorts of laws that changed how the meatpacking industry worked. He wrote the book actually to help the workers, but within 20 or 30 years, you had all sorts of laws that came to fruition that helped the building of unions and bargaining, and all of that came eventually from storytelling. So storytelling is one of these ways we build intimacy between the stakeholders. So what's happening in our healthcare system? Why do we have an intimacy gap? Well, we really have two main stakeholders in our healthcare system. It's not the pharmaceutical companies. It's not venture capital. It's not the insurance companies. The two main stakeholders are pretty much those delivering care, like you and me and the nurses and social workers and chaplains and physical therapists and occupational therapists, all of those people delivering care. And then the other main stakeholders, those of us who need care, like the populace. Those are the main stakeholders. The problem is there is a rift between those two groups. And we've already talked about it a little bit, right? There's the culpability myth. These third parties are trying to divide and conquer and convince patients that doctors and caregivers are at fault. So we already have that gap. But there's also a very natural gap between caregivers and patients, which is called the intimacy gap. What do I mean by that? Well, it means patients come into our offices and they talk about the most scary, difficult things. They bear their fears as well as their bodies. They give unilateral intimacy. We, on the other hand, us caregivers have been trained to be objective and to be distant. We don't give much back. We don't give any intimacy back. And it makes sense, right? Because when you come into your doctor's office with chest pain, you don't want to hear about how horrible of a day they had. But the problem with this unilateral intimacy is it's really hard to come together and share stories when you don't feel connected. And so what I argue is that caregivers need to return some of that intimacy, not there in the exam room, but out in the world. We have to start letting people know who we are. We do a great job of telling people what we know, but we do a horrible job of telling people who we are. I discovered this when early in my career I started blogging about medicine, and I tell these stories about what it felt like to be a doctor, how I would walk in one room and tell a family member and a family that one of their loved ones was dying, and then you'd walk from that room to the next room and someone would be pissed off because you were 5 minutes late for the appointment. And it wasn't that that person who was pissed off was a bad person. They just had no idea what I faced on a day-to-day basis. They couldn't know because we never told them. We never told our stories. We never told them of our struggles. And so what we have is a situation where we have unilateral intimacy, and we need to learn how to tell our stories as caregivers in order to build allyship. And so all of the stakeholders, those who need care and those who are cared for, can actually become allies, because only when we come together are we going to be able to stand up to all these third parties, all these entrenched interests, and fight for grassroots change. This is a pie in the sky answer. I know it's unsatisfying. You're like, I want to know right now what we do to fix healthcare. I want to know what legislation to pass. But the problem is we need a revolution, and revolution doesn't happen from one or two or three pieces of legislation. It happens when stakeholders finally come together and say enough is enough. And that's what I think we need here. And we are getting there. It is happening. If you look at, I can't watch The Pit, the TV show, because it's too real. It brings out my PTSD. But from what I've heard, it is a beautiful example of shared storytelling where we're telling the stories of what it actually feels like to be caregivers. And we need more of that. And that truly changes things. We've seen on a small level how shared storytelling in medicine can change things. If you know who Atul Gawande is, he wrote a book called Being Mortal. And his book about being mortal talked about some of what I would even call the atrocities of end-of-life care in our American system. And since then, we've had a rise of palliative care. We've had an increase in hospice referrals. Storytelling works. His book, Telling Stories about End-of-Life Care, has begun a revolution. We need a bigger revolution when it comes to these third parties and how we pay for healthcare. The only way we get there is we have to change this intimacy gap. We have to go from unilateral intimacy to bilateral intimacy. And the only way we get there is when caregivers start opening up and telling their stories outside of the exam room. Again, not in the exam room, because our patients need us to pay attention to them there. But outside the exam room, we have to start telling people who we are.
Yeah, that's such great information and a great perspective too. And also still feels very daunting and overwhelming. And you can understand that these third parties are so large and there's so many of them. And again, so much money. But like you said, there are so many providers and clinicians and team members in healthcare that deliver care. And we are all patients ourselves, and we have all of our patients too. So there are more of us in number as well. And you're so right about the intimacy gap. We have been trained to not necessarily give much of our background or perspective or things like that because of concern of malpractice could be one thing too. But even just the concern of our safety, right? We don't necessarily want to overshare about our lives because there unfortunately are cases where people come back and find clinicians outside of their workplace and things like that. So there can be that fear with that. But I like how you say don't necessarily do that in the exam room one-on-one, but you can have your storytelling outside of the exam room. You mentioned blogging as a way that you've shared your story, but I'm curious, could you share some other practical ways that clinicians can start sharing their stories and rebuilding their trust with patients?
So there's a whole movement in medicine called narrative medicine, which has to do with multiple things. One is understanding the patient narrative better, but it also means understanding our own narratives. So there's a lot of writing prompts. There's classes in medical school now about narrative medicine where medical students and residents and doctors come together and they write about their experiences and they discuss them. But ultimately, I believe we as healthcare practitioners have to tell the world who we are. I mean, social media nowadays is big and it's open. I started with blogs and then it was Twitter and Facebook, and now people have Instagram. There are many ways we can safely tell our stories, even safely tell our patients' stories, in an attempt to let people know that we are all on the same side. We all have trouble sleeping at night for the same reasons. We are not just doctors, we're also patients, but we're also friends and family members, etc. If you think back to the early 1900s, 1800s, your doctor lived in your neighborhood. Your doctor went to church with you and his kids went to your school and he visited you in your house. We didn't need as much intimacy then because it was already there. They were part of our neighborhoods. But nowadays, most people travel 5, 10, 15 miles to the doctor's offices. Doctors don't see you at home anymore. You don't interact with them out in the world. We didn't need as much intimacy back then. We didn't need doctors to tell their stories because you knew your neighbor's stories already. You knew that your doctor's wife had died last year. You knew that they were struggling with their crops. You knew that he just had a grandson. All of that was something you knew already because you all lived in each other's communities. As we become more detached from each other, this intimacy has got more important, which means we as the caregivers have to tell our stories. We have to be on social media. We have to write articles for our local newspapers. We have to blog. We have to do podcasts. We have to talk about what it means to be a doctor, a nurse, a PA, a nurse practitioner, what that feels like. What are the difficulties we deal with? Yes, there is patient privacy. We can't go and say, I saw patient so and so yesterday, and this is the medical problem they had. But there are ways we can ethically talk about healthcare. We can get people's permissions. We can change the story. We can de identify information, but we have to be out there. Most physicians truly want healthcare to be affordable. Most physicians will give free care if they feel like that's what their patients need. Most of us went into this field because we truly wanted to help people. But unless we make that obviously known, the rest of the world doesn't know that. And it's so much easier to divide and conquer then.
And beside making this change to try to get healthcare better in general, it sounds as though there probably would be benefits for the healthcare providers that participate in shared storytelling, like maybe reduce burnout, maybe it's a therapeutic practice, those types of things.
Yes, I mean, they've done many studies about physicians who write, who tell stories, who express their concerns, have less burnout. They provide better care. Patients actually feel more cared for when they know that their caregivers think deeply about these things. So everyone benefits.
Awesome. And you, again, are a big advocate for financial independence for healthcare providers too. I'm curious how having financial security and different options with our careers can give us more freedom to advocate for both ourselves and our patients.
I think financial independence is the ultimate lever to start practicing and being the person you want to be. So one thing is when you become financially independent, you can focus on the parts of medicine you like most, right? So I loved hospice medicine. I was burnt out by the rest, and that actually gave me the opportunity to do more hospice, something that lit me up, and do less of other things. This benefited me because I burnt out less, but it also benefited my patients because I was able to do the piece of medicine I loved most, so I was able to give them the most of me. When you are financially independent, you can stand up and not sell out to private equity, right? A lot of practices have been forced to sell out to private equity because they just can't afford to exist otherwise. You can decide that you either want or don't want to take certain insurances. You can provide out-of-pocket care and give people more discounts. When you have your finances in order, it gives you ultimate leverage over those who are trying to leverage you. And I think we can use that financial power to do good. And I think always having control of your finances means you're not beholden to those who would really try to use you as leverage to bankrupt the system. And that's exactly what we want to escape.
Absolutely. And to wrap up, if a PA listening or other healthcare provider out there listening or watching this on YouTube, if they're feeling burned out, frustrated, disillusioned with healthcare in general, what is one thing that you hope that they take away from your book?
I want them to know that there is hope. That even when we think our healthcare system is in its bleakest place, if you go throughout the history of the United States, we face this in other things. We faced it in civil rights. We faced it in rights for workers. We faced it in all sorts of places. And your ability to interact, to talk about it, to write about it, to feel it, to express it, you are not alone. We actually can be very powerful when we come together. And there are a lot of us. Almost everyone is either a caregiver or needs care. All of us. There are a lot of stakeholders out there, and our interests are shared. Don't lose hope. This can get better. We can improve things. Just because there are third parties leveraging us doesn't mean there will always need to be. We are supremely powerful when we stand up together and push for change.
Absolutely. Thank you, Jordan, so much for taking the time to share your perspectives, your insights, and for writing your book, The Healthcare Heist. Would you share where they can find the book as well as how the listeners can connect with you if they'd like?
The easiest way is to go to my website, jordangrumet.com. That's JORDANGRUMET.com. You can get this book wherever fine books are sold. The easiest way to do it is go to Amazon or Barnes & Noble online. And if you have any questions or problems, just go to the contact area of my website, jordangrumet.com, and ask me a question.
Awesome. Thank you so much for your time. We really appreciate it.
Thank you so much for having me. I appreciate it.